So without any further ado, I'd like to introduce our first talk. This is entitled The 28-Year Experience with Ruptured and Symptomatic Type 1 through 3 Thoracoabdominal Aortic Aneurysms at a Large Tertiary Referral Center, presented by Dr. Latz. Dr. Latz?
Thank you to the Society for this privilege. We have no disclosures. Our institution began a prospective database in 1987 in which all patients with a thoracoabdominal aortic aneurysm were enrolled. These patients have been followed over time and provide a robust, granular data set for analysis of our thoracoabdominal aneurysm patients. Previously, our center demonstrated a mortality of 8% for all type 1 through 3 thoracoabdominal aneurysms with a spinal cord ischemia rate of 13%, which encompassed both paraparesis and paraplegia, and a renal failure rate requiring hemodialysis of 8%. Overall late survival at 5 years was 73%. A previous manuscript by Cohen et al., utilizing NIS data, demonstrated a crude operative mortality of 54% for ruptured thoracoabdominal aortic aneurysms. However, there is little contemporary data describing ruptured and symptomatic thoracoabdominal aortic aneurysm repair. During this project, the original Crawford classification of thoracoabdominal aneurysms is used, with type 1 encompassing the entirety of the descending thoracic aorta, type 2 starting distal to the subclavian and extending below the renals, and type 3 starting in the mid-thoracic aorta and extending below the renals. Therefore, the aim of this study is to determine the mortality rates for symptomatic and ruptured aneurysms at a large tertiary care center and compare the short and long-term mortality in perioperative spinal cord ischemia to that of elective cases. To accomplish this, we retrospectively reviewed our maintained thoracoabdominal aneurysm database. We identified all type 1 through 3 thoracoabdominal aneurysm repairs between 1987 and 2015. We segregated the cohorts into ruptured, symptomatic, and elective cases. We then identified all perioperative mortality, spinal cord ischemia, and major adverse events. We utilized logistic regression for in-hospital outcomes, and time-to-event analysis was performed with Kaplan-Meier methodology, and adjustment was performed with Cox proportional hazards modeling. Major adverse event was defined as death, myocardial infarction, cardiac arrest, reintubation, respiratory failure requiring tracheostomy, spinal cord ischemia, stroke, unplanned reoperation, renal failure requiring hemodialysis, septic shock, and spinal cord ischemia was defined as paraparesis or paraplegia. There are 516 total type 1 through 3 thoracoabdominal aortic aneurysm repairs. 59 or 11% were ruptures, 51 or 10% were symptomatic, and 406 or 79% were elective. Highlights of these patients are noted here. The ruptured and symptomatic cohorts were older, less likely to be female, presented with larger diameters, and the symptomatic cohort was more likely to have COPD. 19% of the ruptured cohort had chart evidence of transfusion or pressor requirement prior to the operating room, and 70% of the ruptured cohort was transferred prior to presentation, whereas 65% of the symptomatic cohort was transferred. The elective cohort was more likely to receive left heart bypass, and the ruptured cohort was less likely to receive a renal bypass. Total cross-clamp time and operative times were highest in the elective cohort. Postoperative length of stay was higher in the ruptured and symptomatic cohorts. In terms of complications, ruptured patients were more likely to require a tracheostomy and suffer renal failure requiring hemodialysis. Perioperative mortality was 18.6% for the ruptured cohort, 2% for the symptomatic cohort, and 7.4% for the elective cohort. There is a trend toward higher neurologic complications with the ruptured cohort, as well as a higher total major adverse event rate. After adjustment, there was no difference in the perioperative mortality between the symptomatic and elective cases, but the adjusted odds of mortality in the ruptured cohort was 2.6 times that of the elective cohort. There is no difference in spinal cord ischemia rate between the symptomatic and elective cohort or the ruptured and elective cohort. However, the adjusted odds of spinal cord ischemia for those who presented hypotensive or requiring blood products prior to the operating room had nearly 9 times the adjusted odds of spinal cord ischemia compared to the elective cohort. The ruptured cohort had nearly 3 times the adjusted odds of major adverse event rate compared to the elective cohort. There is no difference in the major adverse event rate between the symptomatic and elective cohorts. Survival was decreased among symptomatic and ruptured patients compared to elective cases, with a 10-year survival of 38% among the elective cohort, 21% among the symptomatic cohort, and 19% among the ruptured cohort. The log rank p-value between these three curves was less than 0.001. After adjustment, the hazards of death for the ruptured cohort was 2.3 times that of the elective cohort. There was no difference in survival between the symptomatic and elective cohort. The limitations of this study are several. This series described data obtained from a single center. Its retrospective nature, including variable follow-up and clinical detail, are prone to data inaccuracy or incomplete entry, and there is clearly a selection bias as many of these patients were transferred and therefore hemodynamically stable for transfer. Most of the ruptures did not have evidence of severe hemodynamic stability on presentation. These results must be viewed within these limitations. In conclusion, open, ruptured, and symptomatic type 1 through 3 thoracoabdominal aneurysm repairs can be performed with acceptable morbidity and mortality. Most symptomatic and rupture repairs were performed after transfer from another institution and did not require pressors or blood prior to the operating room. Postoperative spinal cord ischemia is most strongly related to the preoperative hemodynamic status of the patient. Thank you for the opportunity to present our work.
Thank you very much. I'll wait for some questions from the chat. In the meantime, I guess this is a pretty impressive cohort, as we know that you guys have in general. But for ruptured and symptomatic, have you found that this data and knowing these outcomes has changed your practice at all in how you guys approach this?
I wouldn't say it's necessarily changed practice. I think mostly what this project kind of represents is, I mean, these patients that largely come from other institutions, is about 65% of them did. And therefore, are hemodynamically stable enough to come from another institution to us, can still have pretty decent outcomes. And, a 20% mortality rate for ruptures is pretty good. And our symptomatic cohort had excellent outcomes here. So I think it's more of kind of a proof of concept that, we really shouldn't be necessarily giving up on these patients if they're appropriate physiologic candidates for surgery and can tolerate transfer. Then they can still handle these large operations by and large.
Yeah, definitely. A couple questions from the audience. Can you comment on how you try to mitigate spinal cord ischemia in the elective patients, lumbar draining, intercostal reimplantation, things like that?
Absolutely. So especially after 2006, we changed kind of from a more clamp and sew posture to using aggressive adjunctive techniques. Certainly, spinal or lumbar drainage was used very aggressively. We used left heart bypass as well as selective intercostal reimplantation, which was guided by motor evoked and somatosensory evoked potentials to mitigate that, and based off any decrease in potentials, we decided whether or not to selectively reimplant intercostals. But obviously, in certainly the more emergent setting, we don't have the luxury of being able to use all those adjuncts. And in this study, certainly it shows that the hemodynamically unstable patients do worse when it comes to spinal cord ischemia.
Yeah, and I know it's a small cohort, but have you guys seen any changes in this particular outcome over time? Because I know your series extends all the way back to 1987.
Yeah, I didn't do an analysis over time. The major reason being there's going to be a power issue because we only have 51 and 59, if memory serves, for the symptomatic and ruptured cohorts. So I think that's not likely to give us a whole lot of information, but obviously you just do have to understand that our posture when it came to fixing these aneurysms did change in 2006, and that may have had a role in the outcomes, but I don't think we can statistically prove that with these data.
Right. Another question here from the floor. With access now at your institution for endovascular options, have you guys gone back and looked at the comparison for endovascular options? Is there not enough? Or I guess, is there a difference in how counseling is done now for new referrals in 2021, now that you have these different options at your institution?
Yeah, our referral pattern has completely changed given the access to the IDE. However, the thing, it's not really applicable to this study because those take between 6 to 8 weeks to get those customized grafts, and so they're not really an option when it comes to these symptomatic and elective cases. And we don't do a ton of snorkeling or other techniques that you could do under emergent circumstances here. So usually if we get these patients, we're still doing them the old-fashioned way. That is, yeah, patients that come in ruptured or symptomatic.
Yeah, so were all of them in your cohort series done open?
Correct, yes, they were.
Okay, I see. Interesting. Any info from the pre-hospital side of things or from the outside hospital, length of symptoms or anything like that? You had mentioned that most of your patients were very, very stable coming in. Any info from that perspective?
Yeah, that's definitely a limitation here. I mean, we're kind of at the mercy of the index H&P and what they said. So there's certainly there could have been patients that did have a pressure requirement or did receive blood at the outside institution, and unless that made it into our index H&P, we weren't necessarily aware of that. So again, I mean, you really do have to consider the context in which these data were obtained when going through these results.
Yeah, definitely. Another question from the floor here. Do you place lumbar drains in all of these patients? And what is the timing? Preoperatively, immediately post-op, or only therapeutically if they're having symptoms, given that these people are coming in, relatively in extremis?
Yeah, so it would depend on the hemodynamic stability of these. It's actually something I really should look at, is the percent of certainly the ruptured cases that had some sort of lumbar drainage. But I suspect most of them did not, given the fact that we didn't use any other operative adjuncts. In terms of the elective cases, I can speak all type 1 through 3 thoracos, except in rare situations, are going to have lumbar drains at our institution, and they're usually placed immediately preoperatively, in certain cases the night before. They're never placed post-operatively unless they're replaced given new paraparesis or paraplegia.
I see. Have you guys done anything institutionally to try to identify these? Now that you've identified kind of the hypotension and this as a specific indicator of a poor prognosis, have you guys put in anything into place institutionally to try to improve this or remedy this, given that it is obviously an unusual situation?
Yeah, no, I can't say we've done anything from a protocol standpoint, but I do think in terms of patient counseling, when you are immediately talking about patients and deciding whether or not to pursue this aggressive operation, I think that does need to be a conversation that's had with the patient, is that they are at much higher risk of developing this paraparesis, paraplegia, even if they make it through the operation from a mortality standpoint, and then they can make an informed decision based off that.
Excellent. Well, thank you very much for your talk. I think it's time for us to move on. Thank you again.